So hi everyone. It's been a while since I've been at Shoreline, but it's really nice to see you guys, albeit on Zoom. I am here today with Mika Makinen, who some of you guys might remember from when he was the manager at Smoky Point, to kind of walk you guys through the continuous glucose monitoring program that we have live at UWPC now. And then just some key information. So I verified with Tammy, so I know you guys have a relatively new nurse. You have an established RD, so this program will be supported both by your nurse and RD. So there's going to be some steps in the workflow where charts need to be CC'd, et cetera. So just make sure that you include both your nurse and RD on it so they can kind of divide up the work for these patients. So why don't we dive in? Go to the next one, Mika. So what is remote patient monitoring? I think all of you guys know the answer to this question. I think probably a lot of you are doing it informally. Patients are so device connected these days and send us all sorts of information. But specifically, remote patient monitoring is use of devices for monitoring of some sort of biometric data in the home. And you know, as primary care providers, we only have so much time to make an impact on a patient's life and their wellness in the office, whereas most of their natural lives are not in our office and out of our control. So this is really a way to bring medical care into the patient's home, really engaging the patient and engaging our whole care teams. You know, hopefully making our healthcare services, you know, more efficient, more effective, and, you know, maybe stick a little better. You can go to the next one, Mika. Okay, so today this is what we're going to cover. I'm basically going to go nose to tail through the CGM program, show you guys some of the tools, show you guys where some of the resources live for references, just talk about facilitation of care, and we'll talk about some new stuff like the way you bill for this. Go to the next one, Mika. Okay, you don't have to look at this crazy video, but you know, this is available for, you know, clinic leadership or whatnot. And I think this is really just to illustrate how this is really team centric. You know, there's roles for everyone in your clinic, including the patient. One area, I think if you guys remember, we ran this as a pilot about a year ago, and there's one area of the workflow that we really put a lot of thought into and more diligent kind of step-by-step planning from learnings from the pilot. And that's in this swim lane that's highlighted provider, although this is more like team as opposed to provider. But that red and green arrow, it is a little bit confusing to get coverage for the CGM equipment for patients who have Medicare or Medicaid. We'll actually spend a little bit of time on that in this presentation, but that was an area that was a little bit confusing and kind of hard to catch on to during the pilot. So we worked with some of our partners in UW Medicine, and now the pharmacy prior auth team will support kind of gathering of materials to get this covered for patients who are in those payer groups. But anyway, so when we do, or when we did the training for the RNs and the RDs, they get a lot more detailed about this because they're usually kind of the liaison for, you know, the patient that is having difficulty getting their equipment, et cetera. So this is there if you want to look at it. Okay, so first step, who is a good fit for this program? I think you guys know that CGM's been around for a long time. It is absolutely standard of care for type 1 diabetes. Like literally every person with type 1 diabetes should be on continuous glucose monitoring. There are a variety of systems that they use, and predominantly endocrinology. In fact, yesterday I just talked to one of the diabetologists at DCC. Like 100% of people are enrolled with CGM now. So our focus for primary care, though, is going to be on type 2 diabetes. And actually, the woman I was talking to, she's a researcher specifically on CGM and behavioral modification. And that's really the power for type 2 diabetes is engagement in your chronic disease management, in lifestyle changes, and real-time feedback on you know, what happens when you modify behavior, improving outcomes, et cetera. So the focus in primary care is going to be on type 2 diabetes. Now, I know all of you guys probably have patients with type 1 diabetes on your panel. Many of them, for whatever reason, are hesitant to see endocrinology, and you'll just have to use your professional judgment on whether you would be willing to manage CGM for them. Just know that the RNs and RDs are not going to be involved in that care. You know, we made a decision to focus on type 2 just because, you know, there is resourcing through DCC for your type 1s. If they're interested in this service, and, you know, to keep it simple for, you know, our RNs and RDs that, you know, juggle a lot of other things and, you know, would be difficult to pick up, you know, many new things at once. We wanted to focus in on type 2. So patients who are eligible for CGM in primary care have type 2 diabetes and one or more of the following criteria. So I think sometimes when you think CGM, you think insulin, and that's true. You know, type 2 diabetics who are on insulin, even if it's just basal, that's a great fit for this program because they can basically substitute finger sticks for the CGM. However, you don't have to be on insulin to be a good fit for this program. Anyone who's struggling with glycemic control, anyone who would just prefer not to use a glucometer, anyone not meeting their diabetes care gaps, those are good patients. And frankly, this last criterion, the desire to tailor lifestyle changes to glycemic control, I would say that's probably the biggest group you're going to find in primary care. You know, new diabetics that want to do diet, or new diabetics that are starting metformin, or, you know, starting a new exercise program or something, and they want to have some real-time feedback as opposed to waiting 3 months to see what an A1C looks like. You know, even patients who are meeting A1C goal, but, you know, for whatever personal reasons they want to kind of engage this way in their care, this is a good fit for them. Now, there are some exclusion criteria. So if you have patients with type 2 diabetes who are getting care from an endocrinologist, and they want to do this, just direct them to their endocrinologist. And this was more because of billing complexity. These codes can only be billed out once a month, and we just thought it would be very confusing if, you know, endocrinology was billing this and you were billing this, and how are you going to know if they billed it already, et cetera. So this is really patients who their diabetes care home is with you, the PCP. We're also excluding pediatrics, gestational diabetes, and I already said type 1 diabetes. This is more just to kind of keep it simple. You know, I will be coordinating a bit with the Pop Health team once this is all rolled out in all of every clinic. But right now, you know, working with your panel navigator is a great place to start. You know, when you run your diabetes list, anyone who's not meeting their care gaps, you might want to consider, you know, maybe this would be a good way for them to engage, especially since it is a remote service. You can go to the next one, Mika. Okay, before I jump into the ball of wax that is insurance coverage, does anyone have questions about just medical eligibility, meaning who would be a good fit for this program? Okay, cool. So now let's talk about the sticky wicket. Okay, so this is the way that I kind of compartmentalize this in my brain is like CGM is like a brand new medication. You know, a name brand medication that some people's insurance will pay for this condition, other people's won't, or some insurances will pay for it, but you need to jump through some hoops. And this grid right here is current state. Now, CGM is becoming more and more well covered, just like new meds. So I anticipate this will change, but right now this is where we exist. So you're going to have your most flexibility with commercially insured patients, you know, no surprise here. So your Primeras and your Regences and your uniforms, et cetera, they pretty much cover the equipment and the RPM just if you have any diagnosis of diabetes, not impaired glucose tolerance, just FYI. For Medicare, this patient does need to be on insulin, and it can't just be basal insulin. It has to be basal plus, you know, sliding scale for meals, et cetera, and needs to have this quote unquote medical criteria of needing frequent insulin adjustments. That's really just kind of a call by the provider to put in your chart note, et cetera. Medicaid gets a little bit more stringent. They add on this criterion of you need to be asking the patient to be checking their chem sticks, at least QID. You know, I would say patients who are supposed to be getting, you know, basal plus prandial insulin are supposed to be checking QID anyways. That's how you dose your prandial insulin. But yeah, that has to be called out in the chart. Now, the patient doesn't have to be compliant with that. That just has to be your recommendation, because again, CGM is an awesome tool for patients who are just very averse to poking their fingers. And so part of what I'll allude to in this presentation are some smart texts that are available. And we have two that have kind of this insurance-friendly language that have all of this documented in it. So if you're going to try to get this covered for Medicare or Medicaid, it has verbiage about medical necessity and the insulin and the needing frequent adjustments and the self-monitoring QID, et cetera, in there, so that, you know, the prior auth team, if they're going to go send in chart notes for you to support the claim, then it'll all be kind of documented nicely in Epic already. Okay, there are a lot of people though who have Medicare and Medicaid who aren't on insulin but might be really interested in this. You know, I actually have one patient who is young. She's on Medicaid and she has diabetes, and this is really attractive to her. You know, she's what is that generation? Gen Zer, all on her phone all the time, you know, and so she wanted to do this. And so she got them for free through a coupon from Abbott. So there are kind of tricks to get this covered or get it paid for, or cash pay it for not too much outside of insurance. And you might have patients who, you know, are willing to kind of work the system a little to get it. So one, you can call Abbott or check online. There's coupons that often will get you a couple for free. Obviously, you can use the GoodRx trick, and typically you can get 2 sensors for $70, which is pretty good. I mean, that's a month's worth of equipment right there. And, you know, a lot of patients with type 2, they just want, you know, a short-term monitoring to see if their new diet or the new exercise program is helping, and maybe a month of data is enough. And then just the FYI, the codes that are billed for our time have actually been very well covered from all payers. So you don't have to worry about this, literally just the equipment. Any questions about insurance coverage or finagling cash pay? I would have to say the RNs and the RDs are very facile at this now too, in getting patients their equipment in non-traditional ways, let's just say.
Crystal, which one is the least
Yeah.
expensive one? But maybe you just said this, but
Yeah.
Isn't there one that's
significantly less? So we are training for Libre, which was kind of the standard for type 2 diabetes. You know, Savita Subramanian was our kind of content expert for this. It was interesting yesterday when I was talking to this other diabetologist, she was like, oh, you should think about this other one, Dexcom. And I was like, I'm not ready to go there. Because there's, you know, some new device, whatever. But Libre is kind of bread and butter, let's just say, for type 2. And I do think there are some downsides too. I don't want to get too technical in this talk. There is like a new Libre that just got FDA approved, but I had a talk with Allison Everett, and she didn't feel like it was ready for prime time yet. So the Libre 2 prescription, which is the one that we're recommending, is kind of, I don't know, standard. It's not like fancy or, you know, bells and whistles or anything. So we can call it the metformin of CGM. How about that? Any other questions about cash pay or insurance coverage? All right, why don't we go to the next one then, Mika? Okay, so you have a patient. They seem like a good fit. You talk about the program with them. They want to move forward. What do you need to do to get them enrolled? So first of all, you have to put in a consent. This is per compliance, you know, just document that they're consenting to be part of a program that is going to be billed, and there's a nice RPM consent smart text, and we made it really generic because we anticipate in the future we'll have other RPM programs, and then you can just use this one consent. Just remember, you can do this via, I mean, I think most of the time it's going to be in a visit, whether it's face-to-face or telemedicine, but you can do back and forth, you know, on a phone or through MyChart, et cetera, as long as the patient has stated, you know, in their MyChart message, yes, I would like to be enrolled, you know, and you have told the patient, you know, blah, 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 this is going to be billed, et cetera. Then you want to place the referral to RPM. I'll talk a little bit in a couple slides about where that goes, but that's another just stamp, you as the primary care provider are referring the patient to this program that is going to be billed. We try to mimic basically the BHIP consent and referral process, just so we don't scramble our brains too much. And again, that referral to RPM, as we add on more programs, is a drop down in it. So, right now you would use the drop down and choose CGM, but in the future, when we have hypertension or something else there and you're referring to another one, you can just, choose your program. And then this is one of the smart texts. I have a slide that has all the smart texts like aggregated together, but just FYI, this is the one I was telling you that has all of the kind of like medical criteria for insurance coverage written in it. It also has a lot of patient-friendly language, like reminder, what to expect next, the RN's going to reach out to you, this is what the program is, yada, yada. So it's kind of like a nice AVS just to kind of close the loop on the visit where you're going to be enrolling the patient. And then you'll, chart your typical chart note that has the diabetes plan for the patient, and you'll CC it to your RN and RD for Shoreline, since they'll be kind of sharing the load there. That way they'll, one, know this patient's coming, and two, have your diabetes plan written out there, so they know what to kind of coach the patient towards when they start working for the patient. All right, you can go to the next one, Mika. RPM is remote patient monitoring. So that's like a generic term for all sorts of using a device at home. Okay, so you also need to get the patient their equipment. And I think the easiest way to do this, even for Medicare, which requires this to go through DME, is just to write it like a medication. At the next slide, I have like screenshots of the orders, but you basically, if you just type in Libre, it'll pop up the orders. And if the patient does not have a smartphone, they also need a reader. It's just like ordering like a glucometer. So you would need to get them their sensor and their reader, as opposed to their test strips and their glucometer. So same pathway. If they do have a smartphone, most people are just going to use their smartphone. They're going to download the Libre app and just scan their sensor to their phone. So if it's Medicare, though, they have to get the order to DME, because it's not, the pharmacy does not dispense these for Medicare patients. So there is, there are like referrals to DMEs, just like, you order a wheelchair or something. But what I usually do is I just order the medication and I just print it instead of ERXing it. And then I just sign it and give the patient the hard copy. And I say, bring this to a medical supply company. There is an additional form that Medicare, again, as of now, requires, and you have to print this PDF and fill it out. And then, that needs to get faxed to Medicare along with their chart notes, et cetera. So if you are going to attempt coverage for someone who's on Medicare, in our standard smart text for just physician documentation of CGM, there's a hyperlink in one of those vanishing tips that I think we're all kind of used to looking at now. Then you can click it and it'll bring up the PDF that's housed on SharePoint, and then you can print it for the patient there. There's smart set. There's no smart set, although what we're working on with informatics is a smart list. So smart sets are kind of going to pasture. They're kind of old ways to congregate things. And what IT and informatics is trying to push are these smart lists. Like if you guys are doing COVID therapeutics, you should be using the COVID therapeutic smart list, right? You type in that, and then you have like all the links for like, it has like the guidelines for all the different antivirals, like, now EvuShield is going to go live. So for EvuShield criteria, you can use that and read about it. And then it also has the orders on the bottom. But anyway, so we're working with informatics to potentially put one together for CGM, but we don't have that live yet. So right now, they all are kind of have some naming conventions, so they're easy to find, but we're hoping to kind of house them together in one of those soon. And we'll obviously send out a communication when that's live. Okay, why don't you go to the next one, Mika? Okay, and these are just screenshots of the orders. So this person, when they took screenshots, obviously has that pink skin on Epic, which I cannot tolerate other colors besides the blue and the red. So anyways, magenta Epic screenshots. All right, next one, Mika. Okay, so what then happened? So you've done your part. what happens in the sausage making behind the scenes. So your RN and RD will be working the care management work queue, which this referral of RPM maps to, and they'll be pulling it out and they'll say, okay, cool. I have this patient referral from Dr. Shen. Let me, take a look at the chart. And then they're going to reach out to the patient and they're confirm that the patient still wants to participate. And they're going to verify that the patient has their equipment. They might find in their chart review that you forgot to order their equipment, in which case they'll ping you to place orders. But if everything's kind of put in as it should, then they're going to check with the patient and say, hey, were you able to pick up your sensors? And if the patient says no, then they'll kind of troubleshoot that for the patient, whether that was an insurance issue, like, I don't know, I sent it to the DME company and I haven't heard back. They haven't called me that it's ready, or I haven't received in the mail, or whatever it is. Or, maybe we've had a few patients with commercial insurance that, they go to pick it up, but they have a high deductible plan. It's like very expensive, in which case, they may want to use the GoodRx pathway or something. But anyways, your team will confirm.
So that I can see whose phone number is in that 14-year-old's chart.
Oh, that must be just background noise. If you guys aren't speaking, can you please mute? Thanks. So anyway, if the patient hasn't received their equipment, they'll troubleshoot that. If they do, then they'll schedule their intake. Go to the next one, Mika. Okay, I don't think I need to go through this, but this is just basically like what your RN RD is going to be helping the PA team with. And so far so good. Okay, so your patient has been successfully scheduled. The first meeting with the RN or RD is predominantly for device teaching. If you have a really savvy patient who, knows how to use their smartphone well, downloading apps is not a problem, they don't have problems attaching the sensor, which is quite easy to do, et cetera, then your RN RD may be able to do a second part of the visit, which is kind of lifestyle coaching, goal setting, et cetera. But if you have a patient that needs a little bit more hand holding, they'll probably use the whole hour just to do device teaching. And then there is a code that they bill out for that. If they aren't able to do teaching, et cetera, then they might just schedule another follow-up visit with the patient to kind of get the rest of that. And then just make sure, again, highlighted as a courtesy to your RN RD, make sure they have your diabetes plan, because, really the teaching that they're going to provide in the, follow-up plan, et cetera, is all going to be contingent on, what you laid out for the patient. We're going to spend a little bit of this presentation talking about AGP reports and how to interpret those. But I would just say there are a couple of things that, pertinent to this. One is AGP reports are really not valid unless you have 14 days or more of data. So when you're laying out your plan for the RN and RD for check-in, just keep that in mind. Like an AGP report with 2 days of data is not going to be very useful for you in terms of making any clinical decision making. So, just as you're constructing your plan for follow-up. Okay, why don't you go to the next one, Mika? So then the patient is taught, they're off and running, they're using their device, and they will wear this continuously and upload data as agreed upon by you in your plan. The RN will do some specific teaching, like, they have to sync their sensor to their phone at least every 8 hours, or they lose their data, et cetera. And then in between, the RN or RD will be logging into LibreView, downloading the AGP reports, putting them into Epic, and then pinging you with a in-basket encounter that has a standard dot phrase in it. The RN dot phrase that they're going to be using for this communication has a couple of things in it. One, it has a brief collection of the key data metrics from the AGP report, like the GMI and the time in range and any hypos. That way you can look at the message and kind of eyeball it and say, oh, okay, this report doesn't have anything surprising because the GMI is 6.7 and there were no hypos. So I can, keep this aside as a FYI until I see that patient in the visit. Whereas, if you look at it and the snapshot's like, oh man, the GMI was like 14, that's crazy. I better look at this right now and just make sure there's not like a, glucose of like 500 in there or something. So it'll have a snapshot, and then it'll also have a hyperlink in there to the actual AGP report. So it's easy to find because otherwise these live in the media tab. They're also going to put some key metrics into a diabetes flow sheet, which I'll show you. I don't know if it's the next slide or a couple slides, but there's a flow sheet that you can also look at to trend the key metrics from the AJP reports in. So that's actually an enhancement from the pilot. We didn't have that before. So if you wanted to look at what was the last GMI and this GMI and, you know, compare them, you had to kind of open up separate PDFs, which is annoying. So you can go to the next one, Mika. Yep, here's the flow sheet. So the first time you want to look at this flow sheet, you're going to have to type it into the little search thing. You know, you see that little thing with the magnifying glass. So this is called diabetes MA note, and then you can add it to your favorites. And you see those highlighted in yellow. Those are the things the RNRD is going to populate. This person obviously has a horribly controlled diabetes if their GMI was 28. That's kind of ridiculous. I don't even know if that's possible. But we'll put in those and then you can trend them. So if you know you have 3 AGP reports, you'll have 3 columns of metrics. You kind of see what direction they're going. The next one, Mika. Okay, before we jump into actual AGP reports, do you guys have any questions about kind of what happens behind the scenes, what's going to happen with communication with your RNRD, how you're going to access this AGP report in Epic? Okay, feel free to type in things in the chat or, you know, just unmute yourself if you have questions that come up. All right, so this is an AGP report. They look a little bit weird when you first look at them, but they're actually quite simple to interpret and actually much better than I think what we're used to, which is like a little notebook with maybe some scrawled glucoses in it, or, you know, the back of a napkin or something. So really good information for this. So I'll walk you through this. And then there's a link at the end of the presentation to a very detailed education slideshow that Savita put together about how to do this, that goes into a lot of detail. So if you want more content, you know, watch that. It's about an hour. There's also a link to a provider-centric presentation by Abbott on how to interpret these. That's pretty good. And that one's like 14 minutes. So, but anyways, I'll walk you through these. So you're going to get scanned in the media tab, this sheet in a PDF. It's just a one-page report. You can go to the next one, Mika. So this is orienting you to that top right corner, and this has time and ranges. It's pretty easy to interpret, pretty self-explanatory. Probably the most important thing is this green, that's the time in the target range, and the goal is above 70%. A time in range of 70% equates to an A1C of 7. So, you know, just in terms of, you know, apples to apples in our minds. If you have patients who are on insulin, you know, you'll be watching for hypoglycemia, and so your time below range is there, and your goal is less than 4%. How is the range determined? You can see the numbers there, Susie. So target range is 70 to 180, and you can't change the range for the report. This is just kind of standards that are provided by Abbott using the Libre. You can go to the next one, Mika. And then this is the box that's on the upper left. And, you know, if you look at some of the studies looking, you know, really looking at CGM when it was a new thing, this is kind of the target metrics that they defined. Yeah, so the range is the same for everyone. So the biggest thing I think you're going to look at here is the GMI, and that's basically a calculated A1C. If you had an A1C that was based on just the values of this report, it would be that's the GMI. So that would be the A1C basically. So you can see in this example, the GMI is 6.7. So the data enclosed in this report would equate to a A1C of 6.7. Now, you know, that's probably not the patient's real A1C because we know that it takes 3 months. But if maybe the patient stayed with this will of glycemic control for 3 months, you could expect to see an A1C of 6.7. This also has, you know, the date range of which, you know, this covers. And again, you really need 14 days of data for this to have enough oomph for you to actually kind of change medications or behaviors based on it. And it also tells you how much the patient is wearing the CGM or how much they've remembered to sync their data. So this patient was very compliant. They wore it or synced the device 98% of the time, and you want at least 70% of the time of data. Otherwise, you have too many gaps, you know, in your data. Let me check the chat for a second. No, so this is one thing that Savitha highly stresses, Tamara, is that you still need to check A1Cs because again, this is giving you kind of, I don't want to say artificial, but it's giving you this one time shot. It's not actually giving you the actual marker of how well the patient is reducing the risk or, you know, et cetera. So, you know, you could probably supplant some visits by just looking at reports, but you would still want to do your A1Cs Q3 months, Q6 months, you know, depending on how well they're controlled and how many changes you're making. And then also there's this variability. Again, if you do have patients on insulin, glucose variability is important because it just lessens the risk of hypoglycemia. So you're looking for less than 33% for patients who are on insulin. Go to the next one, Mika. And then the bottom, so I don't have a screenshot of the bottom, but this is basically, you know, what you would be engaging with the patient discussing, right? Their glucose waveforms, you know, what is happening during the day, you know, what times, you know, timing their hyperglycemia and figuring out triggers. So here's a simple kind of step-by-step plan for interpreting AGP. So one is, you know, is this report valid? Do I have at least 14 days and did they wear it at least 70% of the time? If neither of those is met, then, you know, you probably shouldn't make any changes based on this report. Two, again, for type 2 diabetes, really the evidence for use of CGM is around behavior modification and engagement in care. So although you can bill out the interpretation of these reports without the patient, I really think that you get more bang for your buck, you know, and more impact on the patient if you are there with them and you're looking at it together. And obviously you can just bill out that code as in addition to your level of service code for that visit. And then, you know, look at the waveform, identify, you know, key things during the day. When did you eat? When did you sleep? When did you exercise? When did you take your meds, et cetera? And then you can kind of look and see what patterns arise from that. You know, I think, you know, a lot of us see this pattern of like, you know, after dinner time, hyperglycemia, you know, because it's too big of a dinner, et cetera. So, you know, you might see that pattern, you know, in kind of real time on these reports. And then, you know, you make your action plan and you document your interpretation. There's a smart text for that just helps you kind of hit all the criteria you need to bill out the code. And then, you know, you'll CC your chart to the RN or RD so that they can know, you know, did you change anything? When do you want me to check the AGP report again, et cetera. So specify that for your teammates that are helping you. Oh, next one, Mika. These are really the smart texts that you will be, or that you'll get familiar with. So one, this is the RN follow-up visit, and that's really what you'll get used to in seeing if a new report's in with a small snapshot of metrics, and you know if the nurse has done any outreach to your patient, any education, you know, communicated something to the patient for you, et cetera. So that's the note they'll be using. The CGM RPM interpretation note, that's what you're going to be using to bill out your interpretation. You can bill that every 30 days. And then there's a treatment AVS that might be helpful for you if you want to give the patient subsequent instructions. You know, you want some text to summarize for them, you know, any changes to medication plan or anything based on their AGP report. And then, you know, you'll just do kind of the back and forth between RN, RD that you're kind of used to with, you know, care management or BHIP or whatever, same workflow. The next one, Mika. Okay, so this is a billing and coding grid that we put together. Really the code that providers are going to be interested in is the second one, the 95251. This is for interpretation of CGM data. And again, it can be billed out every 30 days. It's 0.7 RVUs. Most of the time, you'll probably be billing this on top of a level of service code, you know, for a visit, whether it's face-to-face or telemedicine. The top code is 95249. That's what the RN/RD bills one time for device teaching. And then the 99457 and 99458 are time-based codes that they can bill out on a monthly basis for basically the time that they've worked on, whether it's data uploading or communication with the patient or communication with you or any of that. That's all billable time. It doesn't have to be face-to-face or on the phone with the patient. It's really there to support team-based care around CGM. And those are billed once per month and then in increments of 20, and the max they can bill out is 40. All right, next slide, Mika. I'll share, yep, if the patient agrees to RPN, all of those. Are there copays? You know, we get a reimbursement report from UWP and we have not been collecting copays. And frankly, if patients, this is terrible. I'm getting reported to. We're not going after them if they owe something that their insurance isn't paying, at least right now. I think because the programs are small and the cash dollars are not that big, it's just not worth it. These are charge capture. So that's a good call out, Tamara, because you have to put it in charge capture. That's probably one of our frequently asked questions. It's like, I can't find it. It's like, no, you have to put it in charge capture. So just FYI when you bill out that code. So we'll share some links to where the job aids and such live, but if you want it all in one place, we do have a CGM job aid that literally has all of the resources in one, and it's only 8 pages long, so you might want to just print it, have it at your workstation or something. For providers, probably the biggest thing would be Section 9, which is that billing coding table, Section 10, which is a smart text summary, just to remind yourself of what's there, et cetera. So those are probably the 2 ones you might reach for during actual day, aside from, you know, if you think you're going to try to get a lot of Medicare patients on this and you want to go through their insurance, and you might want a stack of those DME forms on your desk. Just, you don't have to print them every time, but I don't know what your practices are like and if you're going to do that a lot. You can go to the next one, Mika. Then here are the resources I mentioned. So this is a link to Savisa's excellent talk about CGM interpretation. That's the link to the Digital Health Office SharePoint site that houses the RPM job aids. And then that's the link on the bottom for the training video from Abbott if you just want kind of a quicker interpretation video. Let's see. And then next one, Mika, I think that's our last slide. Oh yeah, and then here's just a list of the Epic tools. And again, we do have this on a one pager in that job aid. So this is all of them. And again, when we can get this into a smart list that's more aggregated together, we'll let everyone know. We'll probably send it out with screenshots, et cetera. But this is where they look. And if you just type CGM, you'll pop up all of them. And you can also sift through that list too. So the next one, Mika. Questions? For patients who already have a CGM, can they connect to this program? Yeah, absolutely. Just consent them and refer them, and then you can start billing that time.
Thanks, Crystal. This has been really helpful. Can you kind of share with us about how you've used this in your clinical practice? Just because a lot of us have not been this CGM, so can you
totally?
Like, what does it look like?
I can tell you the real life what it looks like. Okay, what it looks like is you get a lot of tech-savvy patients with impaired glucose tolerance that ask you for it, and then you have to be like, I don't know, or if you want to pay cash, but my nurse is not going to help you, and then you have to bat that away. I would say that for most of my patients who get a new diagnosis, like their A1C finally tips over, I'm doing this instead. It's just super convenient. Patients are usually, I don't know about you, I rarely have a patient who is newly diagnosed who wants to automatically start meds. I mean, most of the time they're like, oh, I don't know, like it's only 6.6, like, do I need to, blah, blah, blah. And so, you know, this is often very helpful to just kind of get them to be like, oh, sure looks terrible after dinner or something, or, you know, inspires them to finally change their diet or do whatever. And for most patients, I would say you're probably only going to use this intermittently. as opposed to this is going to be forever state. Maybe if you have patients who are on insulin that want to exchange this for, chem sticks, then yeah, this will be, permanently their way of watching their glucose and titrating their prandial insulin. But I think that there are more people out there with either newly diagnosed type 2 or type 2 that's now out of control, that they don't know why, or, are just interested and are kind of, most of our population is relatively tech savvy these days, and you're just going to kind of take them on and off. Like I have a couple of patients who, they drop, fall off the wagon sometimes, and then, they're surprised that their A1C is now 7.6, and they don't really want to increase their meds. They want to be better at their diet and stop eating pizza, and, maybe we'll do it for months and they'll get it under control and their A1C will look better. And then, la-di-da. Like I have a couple of patients who have probably gone on and off of CGM like 3 or 4 times in the past 2 years. So I'd say that's in my practice. You may have more patients who are actually on insulin, and this is an excellent fit for patients on insulin because it's just so much more convenient than doing chem sticks.
So if patients go on and off, like I do have a lot of patients who kind of want to monitor before they start meds, that kind of thing. You have to consent them every time, or is there like a time frame within? If you just do it once, they can kind of decide when they want to.
Yeah, I would probably re-refer. Okay, so I would probably keep it on like a year thing. Like maybe if it's been over a year. I mean, my patients that flip flop, it's typically not a year. It's usually like the next A1C is messed up or something. But yeah, I would take that year rule, especially for like the referral, for instance. Treat it like a referral to a specialist. But you don't have to consent them every single time if, you've done it within a calendar year. I don't know, Tamara, you work with compliance. Do you think they'd be happy with Q year? I mean, I think technically if you consented them once, they're okay with it, but I don't know. I'm always like cautious with those lawyers.
Yeah, I think it might be good to document, patient has previously consented and agrees, to re-referral or to, reestablish with the RPM program or something, but I don't think you have to officially reconsent every time they go in and out.
Okay, great, thanks. And then using that code, like the 95251 every 30 days, do you just put that onto charge capture if you're anytime you're reviewing their info, their data?
Yeah, exactly. And I mean, frankly, I think initially you're like, oh no, how am I going to track this? But honestly, are you going to see someone more than once a month for diabetes that's not like floridly out of control? Someone who just wants to see if stopping eating pizza is going to make them better. Like, no, I don't want to see that patient more than once. I probably don't even want to see them once a month. I might want to see them every 3 months. So anyway, so I don't think in practicality, billing that too often is going to be like a real issue. We are pressuring Epic for better RPM modules for tracking, because let me just tell you, this is a pain in the butt for your poor RM and RD. That 20-minute tracking plus another 20 minutes, that is a pain in the butt. But at least the last time I talked to IT, Epic doesn't have anything in the works to make that better, but there's a lot of pressure from a lot of medical systems because many programs are now taking advantage of these RPM codes.
Crystal, 2 questions on that. Can you, oh gosh, I forgot my first question. Okay, I'll go to the second one. Can you do this outside of an encounter with like an actual visit with a patient? Can you build that code?
Yeah, totally. So you could absolutely just put in the interpretation into whatever encounter and bill out the code. I would say, just from a best practice perspective, it's better to kind of talk through it with the patient, but you can bill it out and then still talk through it,
Okay.
Like you get it in your box, maybe, like I could imagine maybe like timing wise, like maybe the patient's only going to see you in 6 weeks, but you have their report and you want to catch this month, you could bill it and then just, not bill it out when you see them.
Okay, great. And then I thought with Savisa's initial presentation on this, I thought she said that you have to actually include that report snapshot in your note. Is that not the case anymore?
You don't.
Okay.
It has to be an Epic, which is why it's in we're scanning it in the media
Great.
tab, but you don't have to have that in your
Perfect.
actual, note. Yeah. I think a lot of the endocrinologists, because they do a lot of it themselves, which is why it never caught on, right, in primary care when Savitha was initially training. I mean, I think she trained us at Ravenna like 4 years ago or something. But, you know, the endocrinologists, they do all this themselves. And I'm like, that's just not going to happen in primary care. Right. Well, you know, this is good to go and live. So, you know, feel free to start using it anytime. And, you know, if there's any clinical questions, feel free to reach out to me. If there's technical weirdness, Mika's your man. He's happy to put in as many IT tickets as you need if something's not showing up. I would say, I don't think you guys are gonna have problems, but we did have some weird issues with some of the Northwest clinics that were brought on because like referral work queues were funky. But if you have anything that seems amiss, like you can't find the smart text, please feel free to reach out to Mika. And then Jen, for you and Duncan, we still have office hours for CGM on a weekly basis that are hosted by Tammy and Ellison. So if there are, you know, operational questions or things like that, feel free to jump in there or send, you know, your RNRD to those if they have questions. So.
Great, thank you. And I'm glad to see that Whitney is with us during this meeting too. Yeah. Whitney, do you have any questions, or can we just start referring? Because this seems like a really great resource for patients.
You could start referring. I've been working with Hugh over here at the Ravenna Clinic and trying to get used to all the smart phrases and, you know, tracking the 20 minutes like Crystal was saying. And I'm still in the learning phase. I'm not as experienced as Christy, the other dietitian, but I'm getting up there.
Great. Feels like we'll learn together.
And I just wanted to say, as far as in this phase, we have to have the training for the RNs, but the great thing is collaborating with the RDs. Like Whitney already knows how to do this, and the RN will be working with her. Okay. So.
Thanks, Tammy.
Okay, thanks.
All right, guys. Well, we'll end our part, and then I don't know if you have some stuff to cover, Jen. You guys can just stay on this Zoom.
Great. Thank you.
And then, yeah, have a great weekend, everyone. See you later.
Thanks, Crystal.